But let's talk about the things that I can't give it up to ER nurses. Okay, so let's can we talk?
You're going to talk about this. Oh, yeah, let's do it. Let's hear it.
Can we please talk about this documentation? Yes. I get that there's a million things going on, but Nyssa, yeah. I get patients. We don't even know their code status. We don't even have a last name for them. We don't know. I mean, you said you get a med history. We don't know any medications that come through. We know nothing about this patient besides they need to be on the cardiac floor. And I'm like, how do you even know that if you don't know? Like, so, okay. So explain to me, how does it happen that the nurses on the floor get patients with very, very little documentation, history, all of the above? How does that happen, and why does it happen?
Okay, so let's break it down. Let's talk about that horrible med list, first of all. We have done this weird thing in our country where we are putting the responsibility on the healthcare provider. You have to investigate their med list. I have to do it in the ER. If I don't do a good job on it, you're supposed to do it, or you're supposed to confirm what I put in there. No one is telling these patients and these family members, hey, you need to keep an updated med list in your wallet. And when your doctor changes it, you need to update it. That is the responsibility of the patient, but no one holds them accountable for that. That's not what our culture says. Our culture says the nurse has to figure it out. And I have spent, minutes, maybe an hour. So imagine that you have a patient who comes in who tells you the pharmacy that they use. You call the pharmacy's not open because it's 2 a.m., or they get half their meds from this pharmacy and half their meds from mail order, and I don't know what the mail order is, or they say they get their meds from this pharmacy, but you call and they say they haven't had anything filled since 2018. Like, it's, you're trying to sleuth it out, and really what happens is it sort of gets dropped on the priorities. Like, I'm working on airway, breathing, and circulation, and I'm going to do what I can for this med list, but if it's 2 a.m. and the CVS is closed, or Publix is closed, or wherever you use, what am I supposed to do with that information? Or like you said, we don't have a good last name for this person. Like, I can't find a med list if they don't have a last name. I can't even look them up in our system to see if they've been here before. There's a lot of detective work that happens in the ER. Yes. We're trying to find family that maybe they can come and tell us something. So it is quite a challenge. And I know you guys feel it on the floor as well, because when we send them up with a half done one or nothing because we couldn't, then it turns over to you. Now you're calling pharmacies and you're trying to find family and you're trying to ask the questions that we couldn't find. The other thing that we do in the ER with documentation is we are doing oftentimes a focused assessment. So when they come in and say that they are having abdominal pain, we're not assessing their toenails. We're not assessing, the
bums for skin. Yeah.
Right. Unless they're a bedbound patient or a, non-ambulatory, then we're not assessing there. So, oftentimes we do a focused assessment. And then again, it has to do with how many patients you're caring for, the turnover of those patients. If I'm caring for 4 or 5 patients in the ER and they're, and I'm turning them, I'm flipping them, I may end up having cared for 10 or 12 or 15, which is one of the reasons when you call me and say, where's their IV? And you're like, I don't remember. Was that Mrs. Jones or Mrs. Smith that I put it in the right AC? And sometimes we get made fun of because of our reports when you call. We always say, I just got this patient, right? Like, that's super famous. Or I don't know anything about them. So, but just imagine that you're caring for 4 patients and now you've got a code or you've got a trauma. It takes 3 nurses to go run a trauma. So I'm getting pulled away from my assignment to go be in there with that trauma. Now someone else is covering my 4 patients and their 4 patients. One of my patients gets a room. We're not going to stop that flow. We want that patient to come up to you on the cardiac floor so that I can put the 87-year-old in triage with chest pain in that empty bed. Like, this is a priority for me. So I'm going to print out a S-bar of my buddy's patient. I'm going to call you and I'm going to say, Q, I'm really sorry. I've been in there one time to help her turn this patient, but I'm going to give you what I can give you because we got to send this patient on. Now, a vented patient on a bunch of drips, probably not. But a med-surg patient, that's why we do that. That's why a nurse will say, I've only had this patient for 5 minutes, or, there's a lot of apple cart turnover. It takes 3 nurses to run a trauma code. It takes probably 2 or 3 nurses to run a STEMI. certainly a code blue, it's going to pull nurses from areas. And then if it's your patient that they were assigned to that's coming up, now someone's got to call you and give you a report so we can keep the flow moving and keep that waiting room, that hot donuts now sign, keep the flow. So I know it's super frustrating for you guys when we're like, I don't know where the IV is. It's somewhere in their body, And I will say on the flip side, one of the things that frustrates us is when we're giving you a report and you're saying things like, what's their diet? And we're like, we don't care. I don't even know. Or this one is that, what do their lungs sound like? Boo, they don't have a respiratory issue. You're going to listen to it when you do your assessment. Unless it's a lung issue, like you need to find out for yourself. I can tell you what I heard, but like I can sometimes hear them clicking in the background. Like, are you doing your assessment based on what I'm telling you right now in report before the patient is even rolled? So it cuts both ways. But I can imagine how frustrating it would be if you got a call and the nurse was saying, I only had him for 5 minutes. I don't know anything about him, but they can get up and go to the bathroom and they have an IV somewhere in their body.
So I respect it. And I really do. I really do. Because the more you talk about it, it makes sense, right? Like, so if you are a nurse on the floor and you understanding that these ER nurses are taking care of 4 patients and they have to deal with everything that they have to deal with in the ER, it makes sense.